All right, welcome. Good morning, everyone. Good afternoon. My name is Jawad Rashid. I'm part of Greenwich Hospital. I'm here to give a talk on back pain, try to demystify just how do you differentiate the different causes, what sort of treatments there are, and just what to look out for even as a patient. So just a little bit about myself. So I'm new to Greenwich. I was in the city prior to this at NYU and Mount Sinai. And me and my colleague, Dr. Richard Zhu, were the two pain management specialists that are working with Greenwich Hospital. Our office is at 55 Holly Hill Lane. Yeah, we're part of the Greenwich Suite where the surgery center is. So I just wanted to just jump right in and kind of give a brief overview on how I structured this lecture, kind of go through all the bread and butter stuff. And then at the end, we can take any questions that are still there. So how I structured this was that I want to initially talk about just the common causes of back pain. There are multiple causes on why someone can even have it. And then I'll go into the different sort of therapies that are available, because surprisingly, a lot of the therapies, they all follow the same sort of pattern. All of these can actually help with all the chronic causes of back pain. And the only places where it's a little different is the sort of injections that pain management physicians can offer you. And I'll talk a little bit more about that. So I wanted to start with just the most common thing that almost the colloquial sciatica, or really what it's called is lumbar radiculopathy. So what it basically is that, this is the type of pain that always usually gets provoked by something. Either you were coughing, you sneezed too hard, you stepped off the curb the wrong way, or the most common is that you bent down to pick something up or lift something up, and you get this sharp shooting pain that starts in the back, kind of goes into your buttock area, and at some point travels to some portion of your leg down. Now, it could be up to your thigh, it could be to your calf, it could be the bottom of the foot. Depending on which nerve is involved, it's will localize that. And how people usually describe it is it kind of starts right after you provoke it. It's very sharp. It feels like someone's sending shocks down. Additional symptoms that you can have are burning, tingling, and numbness. And if it's really bad, you may feel like, wow, my leg is weak. It's really hard walking. I'm not really able to wiggle my toes. And we'll get to that. And, definitely something to watch out for. And like I mentioned, the most common causes, it's you did something to provoke it and you cause a disc herniation in your back. And I'll show you some pictures on what that looks like. And basically that disc in your back and your spine is basically touching one of the nerves either on one of your legs, and that's basically irritating it, causing you to feel the symptoms I just mentioned. Now there's other causes of it too. They're not as common, but I just mentioned any sort of trauma. Unfortunately, if you're in a motor vehicle accident or you fell, something hit you in the back, can cause it as well. Surprisingly, in pregnancy, this is a very common thing as well because of the hormonal changes and the structure difference, the hormones and how they affect your bone and your ligaments. A lot of pregnant patients will also get this as well, and it's really due to the way the belly and the posture, the new posture that you're in now. And sometimes it's just normal, age, and the common theme is a lot of back pain. A lot of the causes are just normal aging, and your bone integrity just gets a little weaker. I mean, some people have osteoporosis, and that it's just a part of normal age wear and tear. Now, how do you diagnose this? So a lot of times just telling you the symptom, like I mentioned, people are like, oh yeah, I feel like I have that at one point. You as a patient, it would be very obvious. It is exactly almost hallmark in terms of acute pain that starts there, goes to some point down the leg. Now, how we diagnose it as physicians is that we would obviously do a physical exam. You kind of come in, the story, a majority of the time does give it away, but what we check with the physical exam is if you have any sort of numbness, some tingling, or even weakness, well, where in the dermatomal or where with the nerves is it really involved in? And we try to piece it together because that tries to help us on, okay, if we do move to any sort of injections, on where I'm going to go in and do the injection. The hallmark of diagnosing would actually be an MRI. The MRI, is when you go into that really claustrophobic tube. It takes about 30 minutes to do, and it really gives a good three-dimensional view of all the muscles, the discs, and the nerves, and we can actually see on the MRI, okay, is there a disc that's hitting a certain nerve? To what degree is it causing the compression? Is there anything else that's going on? Now, the MRI, the thing with MRI, just an offhand thing, is that the way that the insurances are and with all the cost cutting, it's hard to jump straight to the MRI if you do have this issue. A lot of times when you go see any of your primary care doctors or pain specialists, we can really get away with not even having to do the MRI and kind of have a plan in place. But there are reasons to get the MRI. Example, for if you're in a trauma, you always want to get it just to make sure there's no other injuries we didn't rule out. Or if we are doing therapy and injections and it's not working, well, then we want an MRI to see, well, what's really going on. And the hindrance really is an insurance thing, is that when, you have to get a prior authorization, and sometimes they'll be like, well, hey, maybe you should get an x-ray first, or hey, maybe you should try physical therapy and then we'll authorize the MRI. That's just been my experience, but the MRI is the hallmark there. And then I'll mention throughout the presentation just red flags that if you do get issues with back pain, what are the things that you really need to look out for? Be like, hey, I really need to either go to the urgent care, the emergency room, or really call my doctor. And the big things are if you have any sort of muscle weakness, at the point where you can't even stand. Sometimes it's hard to differentiate, oh, is it the pain that's preventing you from standing, or is it really muscle weakness? But with the weak, it's like you can't bend the leg, you can't extend the knee, you can't wiggle your toes, that sort of thing. And then the really severe ones, if it's really involved, is you're having issues going to the bathroom. All of a sudden you can't hold it in anymore, you can't feel anything down there. That's an emergency, and that just means that the compression is to such a degree that you really need to go to the emergency room, because this may be a surgical intervention that needs to be needed. And then I'll just quickly mention the treatment that we offer as interventional pain management, and I'll talk more about it in the slides to come, is what you can do for it is epidural steroid injection. So I wanted to kind of just show some pictures on just what I'm talking about here. And then, so you can see here, very typical, starts right over here, and it can involve just the thigh, the calf, the foot, and what it's pointing to is the different nerves in the back that innervate your leg, and depending on which levels are involved is where you're going to feel the pain. Same over here, and same kind of how this the picture here shows. It's very typical. The patients will come to me like, they'll start pointing to their buttock area, like, hey, it really starts right here, and then it doesn't always shoot down the leg, but yeah, it definitely goes down the leg, and then we kind of go from there. So that's the most common things I've seen. And then just to kind of get a picture of what's really going on in your back, you have, your spinal columns here, the bones that protect your spinal nerves. And these nerves are basically nerves that go to your legs, that give you the feelings, that allow your legs to move, and that sort of thing. Between each bone, you have a cushion, and these are the discs. Very similar to how the knee works too. You have a cushion there, and all your joints, you have some cushioning there so that bones don't touch each other. And like I mentioned, if there's something that provokes it, this disc is in a very tight encapsulated space. It doesn't cost much for it to come out of its socket, so to speak, and to go back and start really touching the nerves over here. And that's really what you're seeing over here. And then here, it's a three-dimensional image that the disc is pushing back over against one of these nerves, and the nerve either goes to your left or right leg to some degree downwards to your toe. And this is just really showing different variations. This is a normal disc, and the disc, loses integrity and it hits the nerve here. Now, what happens when something hits the nerve? Obviously, your body absolutely hates when that happens. And the first thing it's going to do is start to get a lot of inflammation in that area, because you're having material seep out of the disc, and that provokes inflammation because your body says, oh no, I'm injured, I have to start healing myself. And how it does that is through inflammation. However, this sort of inflammation doesn't really come, it comes with some drawbacks, and hitting the inflammation here is what provokes the sciatica sort of pain. The nerve gets inflamed, all these mediators, these molecules start telling the nerves, hey, send pain signals to your brain, tell the person, hey, something's wrong, we got to deal with this, and that's what we're dealing with over here. So now, and I'll get back to that as well in terms of treatment and what you can do about it and sort of the recovery with it. But I wanted to move on with the next most common thing, basically arthritis. You can get arthritis of your knees, your hips, and they can do replacements for that sort of thing. And you can, not surprisingly, get arthritis of your back. The fancy word for that we call it, and what if you get an X-ray or an MRI is lumbar spondylosis. And what that really means is that you have age-related arthritis in your back. The bones are losing their integrity, very common theme here, and either rubbing on each other or again, the rubbing a disc, and you're starting to feel the pain. Then the pain here is a little different from sciatica pain, and this is also something that I think people want to differentiate. This is a very common thing with all arthritis. You're going to get morning stiffness. You're going to feel like, oh, it takes me a while to really loosen up. I gotta walk a little bit to get the pain down. It's a very vague sort of pain. A lot of time it's very dull, achy. It's not so much sharp, although you can have episodes of sharpness if turn the wrong way or something like that. And it's really the difference here. It's very localized just to the lower back. And then I wanted to show you this picture here. Depending on which levels of your lower back are involved, the pain may be just localized to those colored areas. A lot of times what I see is just really the whole thing is involved, because if you have arthritis in one joint, it really just means the lower, you'll get involvements in the other ones as well. And with causes, this is, unfortunately with age, a lot of things that can accelerate this is just poor posture. And I think this is really relevant to nowadays where people are working from home a lot. They're in front of a computer, maybe they're sitting a lot and they're just not as active as they were before. The poor posture, slouching, that sort of thing, really, it doesn't engage your lower back muscles. And that sort of thing can start accelerating the process because your bones start taking a lot of the weight and you don't feel it initially because this is over years and years. And one day your bones are like, I just can't do it anymore. And you start getting this gradual onset of pain. A lot of times I've seen this with younger people too, just weight training, or they're trying CrossFit for the first time and they really become aggressive with it. And the improper weight training or with posture, you can really injure your back pretty badly. I mean, I've had this happen to myself way when I was younger. When I was lifting with squatting, I had pretty bad sciatica for me. So I definitely understand that this can happen to really anybody. And other things can, and the words I'm just going to throw out there, these facet joint hypertrophy and ligamentum flavum hypertrophy, that just means that the ligaments in the joint in your back, they're basically toughening up. And that's just a normal response to any sort of increased stress, either from age, the bones are weaker, so they're trying to grow in other places to handle the stress. But a lot of times when they do that, it doesn't really actually add any benefit, and it grows, but it actually causes more pain because now these pointy edges are either pointing or hitting, the disc or the nerve that innervates your back. And overall, it's an unfortunate, it's a haywire sort of process that goes on. Now, in terms of how do I diagnose? And it's a very similar thing with a lot of pain management is the story a lot of times gives it away. Physical exam is very important because what we do here is we try to load your lower back by twisting you and then putting pressure on it. And if it reproduces your pain, it's really a slam dunk that, oh, hey, this is, axial loading, that sort of thing that you go day to day. And that's where I'm thinking. Here, now, if you wanted to get imaging, X-ray is preferred to MRI because this is more of a bone issue and it's not so much of a soft tissue or nerve problem. Nerve problem in the sense that you are feeling the pain, but the issue is the bone itself. And when you get in any sort of X-ray, the radiologist will comment, hey, you have levels 3, 4, 5, you have some lumbar spondylosis, you have degenerative disc disease, that sort of thing, all fancy words for saying, this person has arthritis. Now, again, with red flags, they're all going to be very similar to each other, is that with any sort of back pain specifically, the things you're watching out for is if you develop any sort of weakness or issues going to the bathroom, those are things that, hey, maybe I should get this checked out sooner rather than later because it could be something else going on. Another thing would be also if you do have chronic back pain and all of a sudden the back pain, the characteristic has changed all of a sudden and you don't think anything, you didn't do anything to cause it. That'd be something to bring up to your doctor. Hey, like I said, my back, all of a sudden it's gotten worse. I don't know what's going on. And the treatment for this, it is different from a sciatica treatment. It's not an epidural. It's something what we do is called a lumbar medial branch block, and a long-term solution called a radiofrequency ablation. And I'll get to that as well. And just showing some pictures here, it's very localized to the lower back. Now, I just want to mention with the sciatica, with the lumbar spondylosis arthritis, these aren't just minimized to your back only, your lower back. You can get this all throughout your spine and your mid back, and the most common other place being is that your neck. And just because the talk is focused more on the lower back, we're going to just focus on that. But I just want people to be aware you can get sciatica of your neck, and that just means you're going to get neck pain and then pain shooting down either of your left arm or your right arm, and you may have the same involvement. It's numbness, tingling. Oh, my hand's a little bit weaker. It's hard to grab stuff. Things to watch out for. With the arthritis, same thing with the neck. You can have the pain just in the neck area. When you turn your head, it hurts. Sometimes people also get associated migraines or headaches with this sort of thing. It's very, very common. And just showing you here, it's all with the bone health here. And then you start to see integrity starts to decrease. And the nerves that innervate your bones, because your bones do sense pain and anywhere in your body, the nerves start firing. Hey, the bone is really feeling it. It's losing its integrity. It's hurting. And you can see, and eventually, you almost get a bone-to-bone issue here. The thing I try to give an analogy to is knee pain, because it's very similar in how this sort of, the process. When you have knee arthritis, knee bone to bone, it's almost the same exact thing here as well. So now moving on to one that not a lot of people have this in their differential or think about this, but it is something that, again, you can have all of these together, which would be very unfortunate, but these usually are isolated. And one is called a sacroiliac joint pain. And what this really is that with your pelvis and really where your two legs attach at the hip and the back, really where your butt muscles are, you have two joints, one on the left and one on the right. And just with all things, you can get arthritis there. And how that really presents is that it's really like the pain is really my buttock area. People will just grab and just be like, it's right there. Sometimes they can even pinpoint it. It's, if you push it, hurts. Sometimes it can radiate into the groin, and that's just the nature of the referred sort of pain. And the things that provoke it is sitting for too long. They have to keep shifting in their seat, going from standing to sitting or sitting to standing. I mean, that sort of movement, because the joint gets involved when you do those sort of position changes, are very hallmark for this sort of thing. Now, as you start to walk and move, it gets looser, because now your muscles are getting engaged and the pressure is getting a little off from those joints. And that's why people usually feel better with that. Now, causes here, you can have a lot of things that can cause it, but I guess the most common is, again, it's just arthritis from either age or posture, but other things, and they're very similar. Trauma, any sort of, did you fall on your buttock? Did you fall down the stairs, the escalators, that sort of thing. Pregnancy, be just with the hormonal changes and how it affects your bones. A big one is here, previous spinal surgeries. Now, let's say you had a sciatica, we tried everything, and I said, hey, I think you really need to just go to the surgeon and you may need an operation, and they get the operation, they feel better. But depending on what they do with the spinal surgery, if they implant any sort of hardware like a spinal fusion, that sort of thing, because of what they do in the hardware that solves one problem, the load of your back gets transmitted upwards and downwards. And the downwards is actually your SI joint. So now the restricted movement of your lower back from the surgery gets transmitted up, and now other parts of your body are taking this extra load that normally they wouldn't have to, because your spine of the middle of your lower back would have been doing this regardless. So I've seen that. And then also with everything with arthritis, just if you're, packing on a few extra pounds, really this is all with extra weight and extra pressure on your bones, that sort of thing. Now, again, how do you diagnose this? Same exact thing. The story usually gives it away. The exam, there's maneuvers that we do to, again, try to load the SI joint and try to pinpoint and push on there. And X-ray again, because this is a bony issue, when you do get it, if it's really bad, it'll say you have some sacroiliitis or sacroiliac joint dysfunction. The X-ray doesn't always necessarily comment because this is more an inflammatory process. So I usually go by more what the patient tells me in my exam, and I don't always need to get an X-ray to actually diagnose this. But if the X-ray, if you happen to get one from somewhere else, and it shows that it's a very slam dunk sort of diagnosis. And again, with just gotta reiterate, just watch out for any sort of weakness, any sort of issues going to the bathroom. And here, what you can do here is a very targeted joint injection, very similar to kind of think of it like someone does a knee injection with steroids. You target the joint itself. And here are just some pictures here. So the sacroiliac joint is right over here, and a little harder to see, but it's this over here. And this is really where the issue is. Again, it's, when people point, it's hard because they kind of encompass both the lower back and the buttock area. But you can see that this is kind of where it originates, and it can radiate down. It can go down your legs, can go upwards. Here, it's very straightforward. And then when I push on those areas, it's you can push enough where you can actually touch the bone with your finger, and it's people, you're like, hey, yeah, I feel it right there, and it's very easy to diagnose with the exam. And then a last one, and this one, myofascial pain syndrome. This usually is associated with any back pain problems, either sciatica, the arthritis, post-surgical issues. And what this really means is that you just have uh, painful muscles, and either the soft tissue of the muscles are inflamed chronically from another condition, or you had sciatica and now you're changing your posture, you're walking differently, and then your muscles in your back are like, hey, why is he like moving differently? Now I'm having to take extra working overtime here, and then your muscles get fatigued, and you also get muscle pain. So this is myofascial pain syndrome, a colloquial term, and usually people who get a lot of massages frequently, either for relaxations, will know that, when either a physical therapist or a masseuse massages you, you're like, hey, I feel that you have like muscle knots. I mean, this is basically what it is. It's a muscle. It's myofascial pain syndrome. Is basically, you have a lot of muscle knots, and you can see here these areas, essentially it's really pointing to almost every point of your back, is very common locations on where the muscles can knot up. And what a muscle knot really is that your muscles, they're, when they contract, they shorten up, and that allows you to either move your arm or your leg or bend. And if they chronically, for some reason, in certain portions of the muscle, if they chronically contract and are not able to relax for some reason, you'll get constant pain. It's almost like a non-ending cramp, but it doesn't feel as bad as a cramp. But you're like, there's something. Why does this point continuously hurt? And you push on it, you're like, oh man, it hurts, and yeah, it even radiates a little bit. And then those are the muscle knots. Now, good thing is that these a lot of times are very receptive to stretching, manual release, which is what a masseuse would do, a chiropractor, that sort of thing. And then what we can do too, if it's still bothersome, or if it's very, very deep, is that we can do trigger point injections. And I'll talk a little bit more about that as well. And so I mentioned the most four common issues with lower back pain. Now, all of them will have very similar treatment plans, and I just wanted to go into them one by one, and then we'll differentiate towards the end and the different sort of injections that we can offer. So the hallmark you have to realize with just pain in general, is that the body's response to any sort of damage or pain is associated inflammation. It could be microinflammation in a certain area, or you can have like an autoimmune inflammation, and that just triggers releases of these neurotransmitters, these mediators, and it's involved in pain. Now, what can you do about that? So you have these very straight, at some point, I'm sure everyone's have taken one of these at one point for another for some reason, non-steroidal anti-inflammatory drugs. And the most common being Motrin, Advil, aspirin, and then some other ones people may be aware of for other reasons: Aleve, meloxicam, Voltaren. And what this does is that this will go, and the enzymes or the proteins that are making these mediators that sense pain, they try to just block them from producing all of this. And that brings the overall inflammation down. And if that's part of a negative reinforcement sort of feedback, it tries to cut off one part of the cycle with the inflammation. Again, it's good for pain relief in general. So any sort of acute musculoskeletal pain, people by all, take it and feel better. And chronic inflammation, anyone with autoimmune disease, or if they're able to take these as well. So I incorporate this a lot if you're able to do it. The only caveat is that if you have any sort of kidney problems or heart conditions like stents, if you're on any blood thinners like aspirin, Plavix, then we have to talk to either your regular doctor, your cardiologist, because these in essence can also cause your blood to thin a little bit. And if you are already on a blood thinner, that your risk of bleeding really goes up. Some of the side effects that just to look out for, because this could mean that either you need to stop taking as much or maybe switch altogether, is heartburn, stomach pain. Now, really why this even happens is because the lining of your stomach is mediated by one of the molecules that this tries to block. So if you take it on a daily basis, people, if you may start developing ulcers in their stomach, and that's really sort of a flag that you really need to maybe readjust on what you're doing. High blood pressure, which in a normal person really isn't that concerning, especially if you're just taking it sparingly. But if someone who has high blood pressure to begin with, it's something that either you need to check regularly to make sure it's not going up, and really be on top of it. And like I mentioned, with bleeding, if you're taking other stuff, and heart risk. So if you have any cardiac conditions, like I mentioned with stents, if you had bypass before, it elevates your risk for cardiac events. And again, it has to do with the balance of the molecules that are involved with bleeding and producing clots. And again, the kind of the gist is that you want to just get clearance from your heart doctor or your regular doctor. And in most cases, they usually are like, yeah, it's fine. Or maybe specifically try this one before, I try to introduce this. So the next class of medication is called muscle relaxers. And I just want to just mention some of the names because at some point you may have heard these on TV. Soma, Xanaflex, Baclofen, or one common one, this is a lot of times this is used just for anxiety, sleep, Valium, for example. And what this is used for is the myofascial pain syndrome that I mentioned, or the muscle knots. That you get associated with some of these other back pain conditions. This medication is really good for that. Sometimes you just have these tight muscles or the knots, and sure, you get a massage maybe once or twice a week, but like, what do you do in the rest of the time? Or if you're getting a lot of muscle spasm or cramping, because that can happen with the sciatica too. Some people may feel like my calf always cramps, and that's definitely a sign of that as well. Well, this medication, what it does is that it acts on your muscle fibers, and it tries to decrease the contraction. Now, that doesn't mean that you're going to become weaker all of a sudden, or you can't go to the gym, or you can't do your normal activity. It just tries to calm the overworked muscles a little bit in terms of the overuse that they've been through, and just give you symptomatic relief. It doesn't solve anything, unlike the non-steroidal anti-inflammatory medications where they actually try to bring inflammation down. This is more just, hey, I need to get through my day, or I need to go and do physical therapy, but my muscles are just really sore and tired. Well, this is what you would take for here. And things to just watch out for is just feeling drowsy, a little dizzy, and yeah, sometimes you can feel weak, although I haven't really encountered that. You could, all these medications, you could actually take them all together. They don't have too much interactions. The only thing is that some of the medications, especially with the pain medication, can just make you feel a little sleepy or a little sedated, and this could be one of them as well. Now, moving on to actual steroids. So how is this different from the non-steroidals that I just mentioned? So these steroids, they're pretty heavy duty. They are very effective, but they also have a lot of downsides. Now, why would I even consider doing a steroid? So let's say you were lifting, you were moving, and you picked up the box, and you had this sharp pain going down your leg, and it's really bad. It's really painful, almost to the point where you want to go to the emergency room. A lot of times when you go, they maybe get an MRI, or they may just give you some pain medication just to help with the pain. A lot of time what they'll do, or even when you come to my office and this is a very acute event within at least, like, let's say this happened in the last 5 days, is that, okay, not everyone can get an epidural steroid injection for multiple reasons, or we don't have the time for that, or the pain is just so bad I need to do something now. Is that, like I mentioned, with all pain processes, you always have that degree of inflammation going. And what this does is that this is pills that you take. It's a tapering um, plan where you'll take it for 5 days and then be done with it. And the steroid is really just to get that really the haywire inflammation that just happened down to a more manageable level. It works fairly well with the sciatica pain, especially if you just have the sciatica pain, just to get people through until your body starts to heal itself, or you're able to see someone for it long-term wise. Now, it is a steroid, so the downside to this versus the non-steroidals like aspirin, Motrin, or Aleve is that this does decrease your immune system, which really isn't a big deal when you take it here and there, or really in this case just once. But people who have autoimmune diseases for that reason will take steroids on a daily basis for that actual reason. And similarly, just like you can take a steroid by pill, and this is an easy prescription that someone can write, this is the same exact thing that we as interventional pain physicians would use when we do the epidural, whereas we target the steroid into the exact location in your back. Taking the pill really just is a shotgun approach and just circulates in your whole body. And then what it's commonly called is a medral dose pack, and it's basically taken for 5 days, and you decrease the dose over the 5 days eventually when you run out. It's not something that you continuously do. It's just hey, let's try this for now. Your pain's pretty bad. If it doesn't work, it doesn't work. It's not like I prescribe another one or try a higher dose. Maybe we have to figure out if there's something else that's going on. Now, coming to neuropathic agents, this is generally when the acute pain, and acute pain meaning less than 3 months, starts to spill over long term, weeks and months, and hopefully not, but years and years. So what do you do if you're like, hey, listen, I tried the injections, but I don't want to get surgery, or I had surgery and I'm still having this pain, and I can't live my life, what am I supposed to do? Well, there are medications specifically that try to target the nerve pain that you're feeling. And with the sciatica pain, with the arthritis pain, yes, the issue is maybe the disc hitting the nerve, or the bone just hitting itself. But the basis of all of this is that there is nerves that are sensing all of this, that are continuously firing and telling your brain, hey, it hurts, it hurts. And that process just unfortunately gets amplified and amplified to the point where you may feel even more pain, even though there's no actual damage anymore. So what neuropathic agents try to do is that the transmission of nerve from either your leg or your back to your brain, it tries to dull it a few notches so that it's not rapidly firing 100 times an hour. It's more like 75 times. The most common ones are gabapentin, or Neurontin is the trade name for it, or Lyrica, or pregabalin. These drugs are, even if you just had an acute episode, they're fairly benign, and I'd be very quick to start these on people. There's the good thing is there's a very high ceiling. You can start very low, and you really titrate the dosing to an adequate level of comfort. Now, if this doesn't work, or you're getting side effects, or it's just not enough, then we can move down to other classes. The antidepressants, and the most common one studied is duloxetine or Cymbalta. Now, they're well known for their antidepressive effects, but they've found research that a lot of these medications also help with chronic pain. Now, it doesn't have to be chronic pain necessarily just from lower back pain. Again, either you have it in your neck, or you had an injury to your leg or your arm, these all, any sort of even chronic knee arthritis, that sort of thing, and it would be, these to start here. And you can start these in conjunction with this, or try this and then go to that, although the preference is usually start here, then go to these antidepressants, and then If that's not enough, or if you really have a neuropathic cause of your injury, to go to anti-seizure medications, because not the preferred thing, but they are also efficacious for this sort of thing. And again, you can use this for acute pain, chronic pain, and they're for nerve-related pain states. The most hallmark being the sciatica. The nerve is just getting hit and hit, and how do we deal with that sort of thing? How do you now? How is nerve pain related from other types of pain? The most easy way to say is that, let's say someone punched you in the arm. Okay, well, that's not really nerve pain. That's really somatic pain. There's a force applied, and you may have a little tissue damage, and that's sending pain. Hey, I just got hurt. That's a little different. Now, that can evolve to go into nerve pain or chronic pain, and then you may consider using this sort of thing. But that's kind of the two ways of thinking about it. So side effects, just to watch out for, like with all medication, it's just a lot of them will make you a little sleepy, a little drowsy, tired, that sort of thing. And so then we get to opioids, or narcotics. And now there's been a big paradigm shift in terms of national prescription practices, and people who probably, or a lot of them are pretty aware, if you're old enough, that you know getting a pain prescription, even the early 80s onwards to maybe early 2000s, was pretty easy to do. You're just like, hey, listen, I got this back pain. Sure, here, take some Percocet, call it a day. With unfortunately with a lot of the drug abuse and the opioid addiction, the CDC and then just the government they've just been forming a coalition on trying to really minimize opioid prescribing. The the practice seems to be well intentioned in the past, where people were giving these out fairly liberally, but now obviously research is showing that these are addictive. That's just the nature of how they are, and yes, they have a narrow spectrum of use, and if you use that appropriately, they do have benefit, but long-term use is where it gets a little tricky. So with any sort of acute process that I just mentioned, sciatica, or you got the arthritis in your back, or you injured yourself, these are really good for that sort of thing. And really the most common times people get prescribed these are either you just had surgery or you went for a dental procedure. And the common ones are tramadol, in the order of how strong they are: tramadol, oxycodone, just Percocet, Norco, Vicodin is hydrocodone, and really strong stuff, Dilaudid, methadone, that sort of thing. Like I mentioned, these are good for, so if someone comes in and I just injured my back, I gotta go to work, like the pain's really bad, I can't sleep at night. Well, I'm gonna prescribe all the other stuff I just mentioned, but if I think you seem like you're in a lot of pain and you may need this just to kind of help with the edge, just for 1 or 2 weeks. At that point, things should start to heal, or we should have a plan in place to see how we're going to address this issue. So the big thing here is they're not meant to chronically being taken. And just an aside with pain management, I've seen in the past, let's say someone had a sciatica, or they injured themselves, or they were in an accident, and their doctors were well-meaning in the past and like, oh, sure, here, I think you need pain medication, but you take it and it works until it doesn't, because you eventually become tolerant to it. If you have pain that lasts for that long of a time, when acute pain morphs into chronic pain, the internal circuitry of your spine and your brain start to alter a little bit, and they become more resistant to this sort of thing. Now, and then you get, some people may get psychological dependence from it as well. And I don't want to go too much into it, but it's for multiple reasons. Chronic pain, with the caveat being, if you have cancer pain, it's not really used for long term. So I want to start to get into some of the other treatments and things that are new that are coming out. And I'll get to the bread and butter with pain management in terms of the injections that we do and what to expect for that. But I wanted to mention, with pain management, we see a lot of people more for chronic pain. And like I mentioned, we have a lot of medication we can try. A lot of it's trial and error, and we can do injections. But what are some new stuff that are coming out? And these are infusions, and the most common, even in mainstream media, you may start hearing about ketamine, even psychedelics and mushrooms I've been hearing about, and how they're really good for mental health and psychiatric issues. Well, surprisingly, they're also really good for chronic pain. And what I realize is that there definitely is a mind-body connection, and one influences the other. And I just wanted to just quickly touch upon this sort of thing. About ketamine. So most people maybe have heard it's a tranquilizer, it's an animal anesthetic. It's similar to PCP on streets. All somewhat true, but how it's been refined and how we use it both with anesthesia and pain management is that when you get any sort of big surgery, instead of just giving you narcotics, which is, we still do that, but we want to also hit other receptors of the brain for acute pain and chronic pain. Ketamine hits a lot of receptors, and they're still trying to figure out, how it really works. And studies have found that ketamine can be very helpful with chronic pain. Now, it doesn't have to just be chronic back pain. It can be really anything. I mean, fibromyalgia, neuropathy, headaches, facial pain. I mean, really, you name a body part and add pain to it, it may be worthwhile trying this ketamine infusion. I just want to mention lidocaine because sometimes these two are mixed together, or sometimes you may just see lidocaine. I just want to focus more on ketamine. I just wanted to throw that out there. It is something that some people offer as well. And how it works is that it is an infusion. So if you wanted to opt to get this, let's say, and how usually people even consider doing this is that we've exhausted a lot of stuff. We've tried the injections, the medications, we've tried therapy. Either you had surgery or don't want surgery. Well, you got to do something. Well, an infusion is definitely an option. And especially, let's say you also have some mood concerns as well. It's, you're depressed, or you're feeling down, so it can be helpful for that as well. So how it usually works is that you would go to anyone's office who offers this, and they would give you an infusion, and it is pretty standardized that you need at least 2 to 3 a week for a certain amount of sessions, because the half-life of the medication is very short. So it goes in, it does its thing, eventually it's going to wear off, and you may find benefits right afterwards, but it's going to wear off. And the whole point of the infusion is that you want to keep bombarding these receptors that may be beneficial and tackling chronic pain with this medication, and in hopes that you do it enough times, you can then stop and you may get some long-lasting benefit. This sort of thing, just as a side, since it's still classified as experimental, even though there's a lot of literature on it, it's hard for insurance to pay for this sort of thing. So it ends up being a very out-of-pocket expense. And it's just something you should be aware of. So now going to some more conventional stuff. So therapy, with all the conditions I mentioned, physical therapy is the mainstay. If you wanted to just do the most organic, hands-off thing that you could do yourself to take control, it would be physical therapy. And I just have to just clarify that physical therapy isn't the same as going to the gym with the trainer, isn't the same as going to CrossFit, isn't YouTubing, or not to the same degree, YouTubing videos on stretches and exercises. The physical therapist, they bring a lot to the table. They really assess your whole body, your gait, what the problem is, and how to functionally rehabilitate you depending on what the problem is. And the first time you go to physical therapy, they're really just going to do an intake, assess you, and that sort of thing, and then to develop a plan for you on how to really get you back on track. Physical therapy usually are multiple sessions a week for about 6 to 8 weeks. Usually is fairly well covered by insurance, and there's a lot of physical therapy, private and hospital associated practices, even in Greenwich. I don't have a preference on where people go. I usually just tell them, if you've heard of a place, or you can even Google it, they're all fairly good, as long as they either targeting what we're aiming for. Now, the important thing with physical therapy is the fallacy that I've seen is this, that majority of the time it will help. It brings the pain down, you're more functional, you get stronger. And then people finish thinking, oh, that's it, I'm done. I completed my class, I graduated, and I should be better. Well, unfortunately, depending on what the issue is, that's really not the case. They will teach you how to do home exercises. It's very important to just be consistent with doing them, not saying every day, but once or twice a week. And because these home exercises will target certain things for the back, the most common issue I've seen is that the glute muscles or the butt muscles are just very underdeveloped. They're not used or activated in normal day to day, unless you're like doing squats every day. They're just not normally activated. That just pelvic strength itself, that takes a lot of pressure from your legs and your upper back. And if you can get those muscles to do their job and strengthen them and take pressure off your bones, well, that will just give you pain relief from the get-go and prevent rapid deterioration of the sciatica or the arthritis from getting worse and worse and worse. Things they use at physical therapy, it's a very dynamic and robust sort of stuff that they use. They'll have massages, they'll have TENS unit, they'll use ultrasound. If you're for elderly patients who can't even, they're just they're not even able to lift weights or move that much. Well, aquatic therapy, I mean, not every place has this, but that's a thing. Just doing movements in a gravity that's less than normal can help you just get mobility and strengthen up that way. So if there was one thing you were going to do for any pain, physical therapy, it's very easy to do. I think it's very beneficial. It's usually always covered, and it's shown to be really long term. This is how you keep things at bay. Now going to other stuff that's up and coming and that I've seen a lot recently, and a lot of patients that either asked me about or gone to and then told me about is acupuncture. And just a little background, it's an ancient Chinese healing technique. And what they do is that their basis is that you have these energy channels in your body, and they'll try to target them with these very, very thin needles. I mean, they're so thin that sometimes you can't even feel that they're in you. And what they found with actual research is that for some reason, when you do this, pain, people's pain gets better. And they found that your body, for some reason, produces its endogenous pain relief molecule by itself. So what I tell people is this, again, we always try to maximize, at least from my take, conventional therapy, physical therapy, medications, maybe we'll do injections. But then once we start running out of stuff, I tell people, hey, listen, acupuncture, chronic pain, it could be chronic pain for anything, fibromyalgia, back pain, post-surgical pain. Maybe it's worth going to acupuncture. Now, some acupuncturists will just say acupuncture. Some are specifically medically trained acupuncturists. So I always say go to a medically trained acupuncturist. They're licensed. It's by the state, so there's some validity to it. And then what I've been told is you usually have to go for multiple sessions, and they'll ask you, where your pain is, and they'll kind of work with you. And overall, the overwhelming majority have found it to be positive, with the only caveat being that some insurance covers this, some doesn't, and the cost sometimes prevents people from doing it. But if you're able to do it, it is by all means. I think it's definitely a great tool to have. So now going on to chiropractic care. This one can be controversial depending on who you ask. It seems to be more of a turf war issue, and then maybe a lack of understanding on what they can offer to people. But basically the gist is that, they're professionals who go through chiropractic school, have their own practice. And what they do is manipulation of the spine, other parts of the body, because, their belief is that there's maybe misalignments, which can be true if, the x-ray may show that, and they try to get that back together. Not all chiropractors, the quality may vary. So if someone's interested, I just say, listen, just ask around, see if someone has gone to one before, and if they think it's helpful, then by all means, it's worth trying out. Situations where I think it may be worth trying out is, especially with sciatica, with either the head or the neck. I've had enough people go that, they'll apply traction to your lower back and take the pressure off, and you do get some immediate relief. And I think they try to get that permanently. Either, they say they're trying to get the disc back in its place. Can't comment too much if that's true or not, but whatever they do, as long as it's not making things worse, and as long as they're not, here's where the bad rep comes from, is really when they crack your neck to such a degree that you start bleeding internally and you don't know that. I mean, it's very, very rare to happen, but that's, I think, where the bad rep comes from. But lower back, that's not as concerned, I think it's definitely worth trying, as long as, like you said, you trust the person, they have good reviews, and you like what they have to say. It's definitely worth trying as well. So now, given to what sort of things can we as pain management do for the conditions I mentioned? So the most common, and the people may hear this colloquially, is, oh, got the shot in my back, I got the epidural shot, that sort of thing. And so the lumbar epidural steroid injection, what it's for is for that sciatic pain. Now, again, you can do this for the head, you can do it for the lower back as well. And this is basically a procedure we can do in the office, but the main thing is that we use a live X-ray to do this, and you're on your stomach, and we X-ray your lower back based on either what you tell me or based on the MRI. I know exactly where I need to go, and depending on which level, I go directly there and inject a combination of steroid, which is really going to do most of the work, and a little bit of local anesthetic just to give you some temporary relief right afterwards. Now, these, again, they're not a cure-all. Some people say, well, what's the point if it's just temporary, or if you're just putting a Band-Aid on? A lot of times with these conditions, yes, your body does try to heal itself. And this is just trying to give you enough of a boost so that at least you're not in chronic pain and you're lying in bed all day, that sort of thing. It gives you enough relief where you can go to physical therapy, you can go to work, you're not having to take pop pills every 3 hours. That sort of thing. We only do these 3 to 4 times a year, because afterwards, it just, if it's either not working as well or it's wearing off faster, then we're really going down to, maybe we need to maximize our thoughts, or maybe we could think about going to a surgeon. Now, the relief can, I've seen everything from lasting from days to months, one and done sort of situation. It's there's no way for me to predict how you're going to react to them, but if you have a very obvious radicular sciatica pain, these most often do help to some degree, enough for you to get back on track and let your body do its thing, and move forward. So that's our bread and butter for sciatica. Now, what about the back arthritis? It's another injection, but it's different. So here, the problem lies with your joints itself. It's not so much the nerve or disc hitting in the nerve, right? So what we do is that we target each individual level of your back. So that ends up being about 3 to 4 injections per side. And how it works is that, again, we use X-ray. You're on your back. It's a procedure we do in the fluoro suite or with the X-ray, and we inject local anesthesia. And what our goal is to see is that after we do these injections, into that evening to the next day, to what degree did your pain improve? The whole goal of doing these injections are that the nerves that sense the pain in your back, we're essentially just trying to block them out, kind of like what a dentist does to your gums. We're just trying to numb it up, and we want to see if that's where your pain's coming from. If it works, even if it's for a very short amount of time, then that's a thumbs up, that we're like, yep, it's arthritis, these injections are working. Well, okay, well, great, it works, but it wore off. So now what are you going to do? I can't get this every single day, right? Well, yeah, exactly. So what you do is something called, for the long-term, radio frequency ablation. And you can do these for other nerves as well, but the most commonly they're used for the arthritis of either your neck or your back. And the procedure is really the same thing. We put the same needles, the same locations, but instead of injecting it with local anesthesia, the needles, they heat up to about 80 degrees Celsius. And doing that denatures, or really just essentially kills the nerves that are in your back. Well, people say, well, hey, wait, is that dangerous? Or wait, if I don't feel any pain, what if I injure myself? Because I thought it was there to signal I'm overworking myself. The nerves that we're trying to target, one, are all sensory nerves, meaning that the only thing they do is sense pain. They don't have feeling of your lower back. They don't move your legs at all. It is literally just for that reason. That comes to the other point. Okay, so hey, okay, I get the radio frequency ablation, and I'm getting relief for months and years now, but the arthritis never went away, right? Well, yes, that's true, but that's why you always do these in conjunctions with the other stuff, with physical therapy, medications that I mentioned, because in the end, you can't reverse arthritis, at least not yet. But what can you do from having it progress, or injuring yourself and making it worse? Well, again, therapy, physical therapy, taking some medications as needed, if there's an acute episode, that sort of thing. Again, this allows you to become more functional, because what we don't want to happen is that you get this back pain and then you're like, well, let me take it easy, and you're less active because you think that's what you need your body to heal. Sometimes that's not the best thing, and you becoming less active makes it worse, because now you're just sitting all day, you're not moving around, then you get more tight in the back, more stiff in the back, and then your muscles are not being used, and then it just goes downhill from there. So this allows you to do your day-to-day, forget about the pain, not dwell on it, and that sort of thing. So usually they're pretty effective. Now, then going to the sacroiliac joint injection, again, it varies. I would compare it to really getting like a knee injection. It's very targeted. This is more like I get it one time and I'm pretty much good. You have inflammation because of either some arthritis, and you just need a one-time little steroid just to bathe that area up, and then long-term relief. Physical therapy. You got to strengthen your glutes up, your core up, and to prevent this from happening again. Again, an office-based procedure, you can do it with X-ray or ultrasound. Usually works fairly well if that's really what the problem is. And then going to myofascial pain or the muscle knots. So, like I mentioned, you can go to a masseuse, chiropractor, that sort of thing, and they can try releasing it. But sometimes either it's too deep or you have way too many points, and you need something a little bit more invasive. Well, what can we do? Yeah, trigger point injection. Really, it's a fancy way of saying we take a very thin needle, either use ultrasound or sometimes just by feel itself, and you basically point to all the locations in your back where it hurts, and I'm going to just poke the needle in and break up the tissue, which is dry needling, or injection is if we actually give some local anesthetic to relax the muscles. And we go in, and this is, you literally could just make an appointment to anyone's office and just any trigger point injection, and we'll just do it right on the spot. There's nothing you need to do, prepare for this sort of thing. Overall, if it's really a muscle component to this, people do feel looser and better afterwards. And these you can repeat fairly often if you really need to, because we're not giving you steroid, we're just giving you local anesthetic, Novocaine, lidocaine, what the dentist uses in your gums. So now going to more involved things that pain management can do. Now, neuromodulation, that's where this field is headed. And I think a lot of neurosurgery is headed to in brain surgery, is that instead of doing these big back procedures or these big brain procedures, is there a minimally invasive way we can still get pretty good benefit with targeting pain? And what neuromodulation really means is that we're going to input something in your back, and where your nerves are, it's going to send out these vibrations. And these vibrations, because your cells communicate really through electronically, it's actually potentials and vibrations, that the vibration tries to almost mask or prevent pain from traveling upward for you to sense it, or reprogram is another way of thinking about it. Now, when would you do this? This is not something some person just comes into my office, I'm like, hey, I think you need this. This is more down the line. Tried injections, either I already got surgery or I don't want surgery, tried medications, tried infusions, tried therapy. I literally have tried every single thing I can think of, and I can't live like this. Okay, so that's where spinal cord stimulation comes in. And the companies that make this, they're finding that there's more and more states that you can try this for, but at least for pain management, the most common is either persistent sciatica, that nothing works even after surgery, back pain even after the ablations, or you had trauma, or nothing's working and you're on pain medication, or you had surgery and then it solved one pain, but then a new pain started, and now they can't do surgery again because you can't really fix that sort of pain. Well, what are you going to do? So how this works is that it's more involved, that it is a procedure that's done in the hospital surgery center. You don't need general anesthesia for this, really just IV colonoscopy anesthesia. And really how it is, it's very similar initially to how an epidural works from our perspective, is that we go with an x-ray, we x-ray your back live, and then we place these very thin wires up your back. There's two of them, one on each side. Once we're there, we connect it to a little box, and the box is a programming tool that has different modes that tries to um, give you coverage of the area that you're having pain from. And let me just show you some pictures on what it looks like. So these two wires that we put in goes up where the epidural is, and then it attaches to this little modulator here, almost, you know, you can think of it almost like a pacemaker that goes for your lower back here, here. Um, and how it works is that if you do have to meet the criteria for this, because this is something that is a little bit more involved. You initially, what you do is we don't just put it in there and call it a day. We do trial first to see if this is even worth, if it actually provides pain relief. And the trial is, like I said, it's a day procedure. You come in, we put these two electrodes. The company that we're using, there's multiple companies. The representative will be there, will help you program and kind of walk you through it for the next 5 days where the trial goes for. And the goal is to get 30 to 50% pain relief. This will not, unfortunately, nothing really in pain medicine gets 100% relief, although we do try for that. But if you get any sort of improvement and you think it's worthwhile, then that's positive. And then you can move on to a permanent solution, which would just mean we would do the same thing, but instead of having an external device, a surgeon would just implant it in for long-term use, almost like kind of like what a pacemaker does. Now let's say, hey, well, that's way too involved. I don't want someone touching my spine. I don't think I can do it with the thing in my back. Well, is there something that's very similar that you can just do by yourself? Well, yeah, there is. People probably heard this. It's called a tension, and it functions on the same sort of basis. It's a device. You can go on Amazon, CVS. It's about $30, depending on which company you buy it for, and it functions the same way, in that you place these stickers in the parts of your body that hurt, and it sends gentle electrical signals throughout, trying to target your nerves that are involved with the pain, and essentially just trying to block them from transmitting pain upwards. Now with the spinal cord stimulator, right, you're not fixing the issue, but then a lot of times in chronic pain, there's no issue to fix anymore. It becomes an unfortunate haywiring of the system that you're trying to combat. So this you can do anytime you have an acute episode, a chronic episode. There is no harm to literally just walking in and just buying one now. Really little downside to trying this, and it's so cheap that some people find this pretty effective. And then getting to more complementary stuff, and then we'll be close to ending. I know time's running out, but medical marijuana, a lot of states have authorized use for it. New York and Connecticut have authorized use for it. Not every practitioner can prescribe it because you do need a special license for it. We do offer it at Greenwich Hospital for pain management. And how it works is, again, you can use medical marijuana as an adjunct, not by itself, but in addition to everything else that someone's doing for chronic pain. And chronic sciatica, back pain, but it's found for other stuff, for mental health, for autoimmune diseases. I mean, you name it, there's probably some research paper that says, oh, medical marijuana may be worth trying. I just want to differentiate, because some people are confused by, well, how is that different from CBD? Because I feel like I can just walk in a store and just buy CBD off the shelf. Well, yeah, that's true. So CBD and THC are two components that are, among other stuff, that are actually in the plant itself. CBD has no psychoactive component, meaning it doesn't make you high, essentially. And that's why anyone's able to make it, and anyone's able to just buy it off the counter. The caveat to that is that the studies usually show that there's a ratio of these, that you need both components to be effective with any sort of whatever goal you're seeking. So that's hard to do, because you can't just go and buy marijuana yet from the store. So what I tell people is this, is that with all the other stuff, easy stuff to do, I mentioned CBD. If someone's interested, hey, why don't you just go buy it from CVS? It may help. There's a lot of variability in who makes it and the potency, and if it's really even CBD, but it's worth trying. Now let's say, okay, hey, it works, it doesn't really work, or the research says it's really the medical marijuana that does the trick. I really want that. Well, okay. How it works is that you basically, see someone who's credentialed, they sign you up depending on where you live. So it's very state specific. If you're in New York, you need someone who has a New York license. Connecticut, you need someone with a Connecticut license. They'll sign you up with the state. The state generally just approves essentially everyone because they'll trust whoever's doing it that, okay, they really need it. And then you just finish the prompts online and you get a dispensary card. And then you go to the certain licensed dispensaries in that state only. And then when you first go, there'll be a pharmacist there. They'll ask you, okay, well, what are you here for? Where's your pain? And then they'll work with you, there's with the different forms, there's drops, edibles, creams, the vape, different ratios you can do. And it's not a one size fits all that you can really tailor towards you. And they're fairly knowledgeable with this sort of thing. So again, this is something either I realize you have a chronic condition, we're not really making headway with any other thing, but you need some sort of relief and you're open to it. I'm fairly open to trying this out as well. The only downside is it's not covered by insurance. So there's a small fee I think you have to pay when you get the card from the state, and then when you go to actually buy the product from whichever dispensary you go to. And there's just other stuff just to be aware of, that certain deficiencies of vitamins can be implicated in chronic pain, the most common being vitamin D. Other levels that sometimes if you go to neurologists, they'll check B6 and B12. If you have chronic pain and you're going for your normal annual physical, I'd recommend just asking your doctor, can you just check these levels for me? Because a lot of times, those vitamins being deficient, they don't allow the other stuff to be efficacious in helping with the pain. Other stuff, let's say more complementary stuff that research have shown, turmeric, fish oil, alpha lipoic acid, and these are more implicated for inflammation. And like I mentioned, hallmark of your body with pain or any sort of trauma is that it's going to go into inflammatory mode. And this tries to quell long-term runaway inflammation that isn't being productive to anything. And just want to reiterate the red flags, like weakness, issues going to the bathroom, if you have other stuff, fever, weight loss, past history of cancer, if you take blood thinners, you really want to maybe contact your doctor, because you want to make sure that, okay, did you not have a relapse, you're not internal bleeding for some reason, or there's no infection that's somehow you want to make sure there's no that, because these things can really get out of hand very quickly if you don't address them fast enough. Well, so now just want to touch upon surgery, because when do I actually go surgery? And if anything, I have more people going to a surgeon first who then get referred to me as pain management, because they're like, no, you need to try some of these things first before we do surgery, because surgery has its pros and cons in itself. So my criteria, or what I think it's for people for surgery, is that just because you have back pain doesn't mean you have surgery. So I think that's a fear of a lot of people. So that's one. Two, when would I send someone to surgery? The degree of the issue and or how long this has been going on for, and the response to stuff that I've tried so far. So if you have any other red flags, weakness, bathroom problems, I'm going to straight up just tell you, either go to a surgeon or even just go to the emergency room, because they need to make sure that your back, there's something acute that needs to be warranted with your back. And the reason I say this is that, let's say you have a really, really bad herniated disc and it's literally cutting off your nerve to your leg. That's something you need the surgeon to go in right then and there and fix, because the longer your nerve gets cut off, the prognosis of fixing it later and trying to regain any function, really goes downhill from there, unfortunately. So anytime you have that, it's don't even think, I would just go straight to the emergency room. A second aside is that, okay, we've tried everything. The pain's still disabling, and you didn't want to do surgery now, but either it's getting worse or you can't live like this. And I'm with you, I'm frustrated with as well. Sometimes you just have to go to surgery, and there's a lot of back surgery isn't just one thing. It's depending on what the problem is. There is different actual surgeries that they do. The good thing is that a lot of these surgeries are trying to become minimally invasive, or they're really not trying to fillet you open and just muck around in your back. They have microdissectomy with microscopes. They have the spinal fusions, the decompress and stuff. And, depending on what the issue is, this may be the one thing you need to get better. I mean, again, it's hard for me to say if these will work, but that's why you go and get a consultation, because generally, at least in this area, I found that the surgeons are pretty conservative, that they will really only do it if they think there's some benefit for you in getting these surgeries. Because the downside of back surgery, and I've seen this too, is that you do get it and it helps for one thing, but then you get pain from the surgery itself in another area, and now what are you supposed to do? It's not that common, but it does happen, and it's a little tough. Or people will say, hey, my friend got back surgery and they're even worse off than had they not gotten, and I don't want to end up like that. Well, sometimes that's the nature of the game, which is why I think depending, who you go to, where you go to, quality is important. And I think around here, you have really good quality surgeons. If anything, just to get a quick consultation. Hey, is it? Do I need to get surgery, or you think I should just do my physical therapy or stuff like that? Just some references, and that's it. So I'll take some questions. So, okay, so one is, I'll start in the order that I'm getting. Is there any certain type of mattresses that would help with morning stiffness related to arthritis? So sleeping posture definitely has been implicated. And not just the mattress itself, is also the pillow. Depending on where your pain is, the pillow is definitely more for upper back, neck pain. The mattress generally too, and also what position you sleep on. Is it your back, your side, your stomach? If you ever seen someone in pictures on how they sleep, you realize that if you toss a turn a lot, you may be moving your back with arthritis, and you wake up and you're feeling, why do I hurt so much? Well, you are moving around a lot. I do think mattresses and pillow to that extent are helpful. I can't comment on if there is a certain type that's beneficial, but seeing with the Tempur-Pedic stuff, or the foam memory pillows, and based on at least what I've looked into, Curse, even for myself, it seems like it tries to mimic your body contours and kind of snugly put you in, so that your back isn't misaligned. Basically, your head isn't too far up, your hips aren't too far up, that sort of thing. I do think there definitely is helpful. I can't really give you any more suggestions than that, unfortunately, but that, along with, like, for example, putting pillows between your leg, or even snuggling with a pillow, I think can help with this sort of thing. Next one is, let me see. So let's say you're playing a sport, you injured your back, and it's still kind of there. Well, what sort of things can I do to help with that? But yeah, by all means. So with your back, the two biggest things are going to be your glute muscles, and there's two of them. The big ones: gluteus maximus and gluteus medius, and just your lower back, the erector muscles. If you want to do something on your own, what I would say is either go to YouTube or go to Google and type in exercises to strengthen your glutes and your lower back, because they're very big muscles, and they're every day you're using them. I think if you strengthen those, will help with some of the overuse stuff that you're feeling. And again, of course, over the counter and inflammatories, if you have time to actually go to physical therapy, may be beneficial. But if you just wanted, hey, what's something I can just do on the daily? Those were the two things I would target: the glute muscles and the lower back muscles, and the most common being the erector spinae muscle. For lower back pain, is it better to treat with cold or heat for temporary relief? So depending on what the issue is, if it's a muscular issue, heat seems to do better, because heat relaxes your muscles, and in any sort of either spasms or tightness or soreness helps with that. If it's more of a bone issue or an acute injury issue, I found that cold seems to help, because I think cold decreases the transmission of the pain itself. It just slows it down a little bit. But in a practical standpoint, you could really try either or and just see what works for you. I mean, a lot of times, even though the paper says, "Oh, hey, this is helpful," it really just comes out to what works for you. But that's what I've seen. Heat more for muscular, cold more for arthritis, back sort of thing. Um, can you take COX-2 inhibitors as well as gastric bypass? Uh, so that's a good question. Assuming you don't have any cardiac issues or anything like that. I mean, the thing with the gastric bypass, I'm not too familiar, is just your absorption levels at that point with any sort of medication, just because now you're bypassing most of your stomach going straight into your intestines. I think from trying to just rekindle my memory, as long as you don't have any sort of inflammatory bowel disease, cardiac issues or anything like that, nothing that I can recall prevents from taking a COX-2 inhibitor. Again, this usually kind of goes out of my way, and that's why I always defer to the specialist to do this, either your bariatric surgeon or a GI doctor, just to say, hey, is there going to be any effect on the anastomosis of where they went for the surgery, that sort of thing. I can tell you this, though, that when we do bariatric surgery from an anesthesia standpoint, very often we give Toradol or Ketorolac, which is, an NSAID, very similar to a COX-2 inhibitor, and generally no concerns usually there. So I would say, I mean, the safest would be to just ask your surgeons, but from what I've seen, not that I'm aware of. So, so I think the next anonymous question is that I have spondylosis at a certain level with pain in the scapula. So spondylosis, all right, like I said, it's arthritis of your neck. With arthritis, and if you recall the picture, I don't have one of the neck, but just like with the lower back, arthritis of your neck can give you certain referral patterns. And sometimes people confuse arthritis with, oh, I have a sciatica of my neck, because I feel like the pain's going to my shoulder or my upper back, that sort of thing. You could definitely have both associated with the spondylosis and pain to the scapula. A lot of times what I've seen is with the upper back, the trigger points are usually more common when you have issues with the upper back than the lower back. So could it be that you have just a referral pattern just from the spondylosis itself? Maybe. Could it be you have a trigger point in that scapula area because of the picture with all the dots? Scapula is definitely a big one for a lot of people as well. I think an easy fix, I mean, if you haven't already, physical therapy or have them look at it for sure, because again, with this long term, it's just strengthening your back. Now, if it is from there, and let's say we do these medial branch blocks, like for the arthritis, if it really is coming from the arthritis, that radiating pain should get better with these injections, even if it's just temporary. I think it could just be a referral pattern. I haven't seen too much referral radiating pain that's caused by an actual disc herniation that goes to the scapula, more so because the nerves that are involved usually are shoulder downwards. But yeah, again, it could happen. But I think, that seems to be more the common issue. I think it could just be referred from the spondylosis. Working outside of lifting causes pain afterwards. Wearing a belt help. Belts, you'll hear mixed things depending on who you ask. One benefit is that if you have an acute injury or you had surgery and you need to take the load off your back in short-term time frames, having a belt is definitely helpful, and takes the pressure off and that sort of thing. Long term, the reason why some people may not like you using it is because the muscles that should be doing the work of the belt, you're using them even less than you were before, and you're going to get heavily reliant on the belt because now your muscles are getting weaker because you're not engaging them as much, and you may actually cause more injury if the one day you decide to take it off and just do your normal day-to-day. That's the theory I've heard. I think if you're going to just use it sparingly here and there, by all means, I don't think there's any harm in that, but I wouldn't use it every single day going forward. I would try to see if, depending on what sort of work you're doing or where your pain is, if there is, again, physical therapy, is there sort of strengthening that you can do or better posture with doing this sort of thing. Um, how long pain free for, so if, so it's hard to say. It's hard to say, well, what's the correlation of how much pain do you feel versus, well, at what point are you going to actually cause real injury to either your joint, your ligament, your tendon? If you're playing tennis, once or twice a week, and you're giving yourself enough recovery days, um, and when you start to swing or stretch a little bit, and for the most part you feel okay, I think that's okay for you to go and play your sets. I just think that, let's say you're the US Open, and you're doing it every single day competitively. I mean, that's where you start to maybe run the risk that, even if you do take medications for it, injury can be a real issue there as well. But I think if it's just recreational, like it seems like what you're doing, as long as you give yourself a few days worth of break, I think it's okay. Now the caveat is that if your pain gets worse, and the healing isn't as robust as it was, well, did you injure a ligament or a joint or something? Because those things don't fix overnight. Those do take a little bit of time, and it may be worthwhile just seeing either a sports medicine person or a physiatrist to kind of check them out. Well, okay. Well, I had really fun just kind of demystifying all of this, and I hopefully answered all the questions that you guys had. Just wanted to reiterate that, we're here right at Holly Hill Lane, me and Dr. Zhu. Now, there's a lot of pain specialists in Westchester and Fairfield in Connecticut, which is a good thing. So there's a lot of options for people. I'm not saying you have to come to us for any reason, but I think, wherever's closer to you, we all are generally trained the same way. So we all usually offer this to some degree. So wherever you can, get in, and hopefully you can get treatment quicker rather than later, having to suffer for longer unnecessarily. All right, well, take care, guys. You guys have a good day.